You are so warmly welcome to this medal education session focusing on HER2 positive metastatic breast cancer. If it is the first time that you are joining us here today, you are so warmly welcome, and I hope you find this session incredibly useful. Our passion here at Medal is making great medical education accessible for every healthcare professional everywhere. So wherever you're joining us from today, I hope you find this really educational and useful for your practice. We have got an incredible session for you today with Dr. Sarah Sammons, and this is going to be a really interactive session with lots of discussion, so I hope that you're ready for it. We're going to have time for questions at the end, so please pop your questions into the chat box on the right-hand side, and we will pose those to Dr. Sammons in our question and answer time. Before we go any further, it's really important that we share our disclosures with you, and I'm going to bring those up on the screen just now so that you can see them. And then we're going to take a look at our learning objectives for today. And our learning objectives today are to evaluate multi-drug maintenance strategies in HER2 positive metastatic breast cancer, to apply patient-centered quality of life focused decision-making to personalize maintenance regimens, and to evaluate guidelines and the latest evidence to understand the treatment paradigm and first-line standard of care evolution for patients with HER2 positive metastatic breast cancer. But before we dive into our education today, I want to understand just how confident you are in these topics before we begin. So I'm just going to launch a few polls, and I'd love to hear your thoughts before we dive into this education. So I'm just going to bring the first poll up on screen now, which is this: how confident are you in evaluating guidelines and the latest evidence to understand the treatment paradigm and first-line standard of care evolution for patients with HER2 positive metastatic breast cancer? 1, not confident, up to 5, very confident. If you could share your thoughts in that poll, that would be great. And if you're joining across one of our social channels, you've got to join on Medal next time, and you'll be able to join in on our polls. If you're just joining us, we're doing some polls. They're on the right-hand side of your screen if you're joining on desktop in the messages box. If you're joining on mobile, just hit the little chat icon at the bottom, and you'll be able to see all of our polls right there. Okay, I'm going to ask you for your thoughts on a second poll, which is this: how confident are you in evaluating multi-drug maintenance strategies for patients with HER2 positive metastatic breast cancer? Not confident, right up to very confident. If you can share your thoughts, that would be great. And if you missed the first poll, you can scroll up in the chat box on the right-hand side of your screen on desktop. Just hit the little message icon on mobile. You'll be able to scroll up. You'll be able to answer each of the polls. If you missed our first one, don't worry. Okay, thanks folks for your thoughts. Just give you another little second. And then our final confidence poll today is this: how confident are you in applying patient-centered, quality of life focused decision-making to personalize maintenance regimens for patients with HER2 positive metastatic breast cancer, particularly those with brain metastases? 1, not confident at all, right up to 5, very confident. If you could let us know in the polls, that'll be great. And if you've missed the first poll or the second poll, you can scroll up in your chat box on the right-hand side, and you can hit an answer on each of those. If you're joining on mobile, just hit the little chat icon at the bottom and then scroll up in the chat, and you'll be able to see each of those polls in turn. Thank you for sharing your thoughts so generously. And guess what? We're going to be covering each of these topics in our education today. So I hope if you're not confident at the moment, I hope that this is a really useful session. I hope if you are really confident that you find that this helps reinforce some of your existing competencies. We are going to move on to our session with Dr. Sammons now, and it gives me really great pleasure to introduce Dr. Sammons, who is Associate Director of Metastatic Breast Cancer Program and Senior Physician and Associate Professor of Medicine at Harvard Medical School. And she is going to be talking to us today in discussion and presenting some cases. So stay tuned. You're going to have a few more polls about evaluating multi-drug maintenance strategies, applying patient-centered quality of life focused decision making, and evaluating guidelines and the latest evidence. So I'm going to hand over to Dr. Sammons just now.
Hello, my name is Dr. Sarah Sammons from Dana-Farber Cancer Institute in Boston, Massachusetts, and I am thrilled to be here at the MEDAL Grand Rounds to discuss optimizing therapy in HER2-positive metastatic breast cancer with a particular focus on the evolving landscape of the first line. These are my disclosures. The learning objectives today are to evaluate the guidelines and latest evidence to understand the treatment paradigm and the shifting treatment paradigm of first-line standard of care evolution for patients with HER2-positive metastatic breast cancer. We will also evaluate multi-drug maintenance strategies, including CDK4/6 inhibitors. And then we will also focus on applying patient-centered, quality of life focused decision-making to personalize maintenance regimens. For case 1, we will evaluate the latest evidence to understand the treatment paradigm and first-line standard of care evolution in HER2-positive metastatic breast cancer, synthesizing current guideline recommendations and top-line recent results. We will also map decision points from induction through maintenance and later line transitions. So for case 1, first we have a 45-year-old female with a past medical history of stage 3 estrogen receptor negative, HER2 positive breast cancer. She presented in 2024 with a T3N2 estrogen negative HER2 positive breast cancer and received TCHP × 6 neoadjuvantly. She then underwent lumpectomy and axillary lymph node dissection, showing RCB2 disease. So she had a fair amount of residual disease. She then completed 1 year of radiation and also 1 year of adjuvant TDM1. Unfortunately, in September the following year, so about 18 months after she completed TDM1, she presented with headaches. MRI revealed 3 brain metastases. PET-CT scan was performed to evaluate her extracranial disease, which showed PET-avid hilar lymphadenopathy. Biopsy of her hilar lymphadenopathy revealed a metastatic recurrence of her estrogen receptor negative HER2 positive disease. She went on to receive stereotactic radiosurgery to her 3 brain lesions. What is the best systemic therapy choice for her now that her radiation to her brain is over? Trastuzumab deruxtecan, with or without pertuzumab, docetaxel, trastuzumab, pertuzumab, trastuzumab, pertuzumab plus tucatinib, trastuzumab emtansine, or trastuzumab alone. Thank you so much for your answers. It's certainly an evolving landscape.
Dr. Sammons, thank you for presenting that case. Could you briefly summarize the key findings from Destiny Breast 09 that compared T-DXd plus pertuzumab to the standard THP regimen in this exact first-line setting?
Yes, absolutely. So after more than a decade of having the same standard of care, we recently presented at ASCO 2025, had a new positive study that is likely going to be practice changing in the first line for metastatic HER2 positive breast cancer. Destiny Breast 09 was a phase 3 international multi-center randomized trial that evaluated trastuzumab deruxtecan plus pertuzumab, trastuzumab deruxtecan alone or the previous standard of care, which was the Cleopatra regimen, which is a taxane plus pertuzumab and trastuzumab in patients with first-line HER2 positive metastatic breast cancer. About half of the patients had de novo metastatic disease, and about half of the patients had recurrent disease. There was a mix of estrogen positive or estrogen negative patients. Patients were allowed to have stable brain metastasis at baseline. And what we saw was a striking improvement in progression-free survival with T-DXd plus pertuzumab versus the previous Cleopatra regimen or taxane HP. The progression-free survival with T-DXd plus pertuzumab was around 40 months versus around 28 months with the control. We have yet to see overall survival from this regimen, but other endpoints, including overall response rate, complete response rate, were also improved with trastuzumab deruxtecan plus pertuzumab. In the forest plot of the subgroups, we saw that pretty much all patients had benefit from trastuzumab deruxtecan plus pertuzumab versus the old standard, including patients with a history of brain metastasis had a pretty striking benefit with T-DXd plus pertuzumab. Patients with the PIK3CA mutation had benefit regardless of estrogen status, regardless of visceral disease, de novo versus recurrent. The T-DXd plus pertuzumab population did quite well versus the previous THP standard.
Given this dramatic improvement in progression-free survival, should T-DXd plus pertuzumab now be considered the new standard of care for this patient?
That's a really good question. So we're currently in a setting of limbo. The results of DESTINY-Breast09 have been presented, but regulatory authorities have not fully approved trastuzumab deruxtecan plus pertuzumab in the first-line setting yet. I think we are all pretty optimistic that they will in the near future, but at least right now, it's not quite approved. What we do have approved is T-DXd was previously approved in the second-line setting based on the results of the DESTINY-Breast03 clinical trial versus T-DM1. And T-DXd, at least in the US, is approved for patients who have relapsed within 12 months of their adjuvant therapy. This patient was just over 12 months since her adjuvant therapy, so she doesn't quite meet that criteria, but I certainly would be thinking about T-DXd for this patient in the first line for a couple of reasons. One is she has had relapse, in pretty short succession after she already had taxane, trastuzumab, pertuzumab, and a year of T-DM1. We're about a year later, and she now has new brain metastases and hilar lymph node involvement. So this is someone that I would definitely want to be thinking about trastuzumab deruxtecan for if I had regulatory approval. If we're talking about pure sort of guideline driven, she's technically out of that 12-month range of relapse, and we do not yet have regulatory approval for DESTINY-Breast09. So re-challenging her with a taxane HP would be very reasonable. But I think most of us will await regulatory approval, and once we have it, we'd certainly be thinking about T-DXd plus pertuzumab in this patient.
This new regimen involves continuous ADC therapy rather than a finite chemotherapy induction. How does this shift our thinking about maintenance and long-term quality of life?
Yes, so that is really the main criticism, I think, of the DESTINY-Breast09 clinical trial, where patients in the first-line setting were randomized to either the T-DXd plus pertuzumab arm or T-DXd arm. They got continuous T-DXd with or without pertuzumab until progression or intolerable toxicity. Whereas the old paradigm in treating metastatic HER2 positive breast cancer was in Cleopatra, patients got 6 to 8 cycles of cytotoxic chemotherapy with a taxane. And then we pulled off the chemotherapy and the patients just continued their monoclonal antibodies, trastuzumab and pertuzumab, with endocrine therapy if they were ER positive. And that gave them pretty excellent quality of life. And some of them could do very well, for years on that regimen, without a cytotoxic chemotherapy payload, without cytotoxic chemotherapy. And so, this shift to bring T-DXd into the first line continuously until intolerable toxicity or progression really takes away that maintenance, excellent quality of life for our patients. And I think that is of concern. And, I think we are going to see more and more maintenance trials, either with T-DXd induction or, with T-DXd induction or other novel agent induction, because giving our patients quality of life in terms of maintenance will remain important.
What are the key toxicities we need to counsel this patient on with T-DXd, specifically regarding ILD?
So let's say we were able to get, approval for first-line T-DXd for her, because she's had relapse so quickly after T-DM1, and because she had brain metastases, which I think, at least in the US, you could probably petition for. Things that key toxicities that we're counseling patients about with T-DXd are fatigue, nausea. This is a pretty highly emetogenic drug. And so we do recommend a 3-drug antiemetic regimen when it is delivered in the clinic. And then we're certainly sending patients home with antiemetics. I personally am sending patients home with 2 days of steroids on day 2 and 3 as well for nausea purposes. We're also counseling them that there is a 10 to 15% risk of interstitial lung disease. And in the newer clinical trials, very few patients died from this, but in the earlier trials, patients did. And so we really need to counsel patients to get in touch with their medical teams, on the urgent end if they're having cough, shortness of breath, anything like that, so that we can do a high-resolution CT scan to make sure that they don't have interstitial lung disease. And certainly if they do, we are, withholding the drug until resolution. Oftentimes you can treat with steroids, pulmonology referral, all of those things. Right now, the guidelines say that you could re-challenge T-DXd after grade 1 pneumonitis. If a patient experiences grade 2 pneumonitis, currently guidelines say that we should not retrial those patients with T-DXd.
How do we engage in shared decision-making here? What factors, comorbidities, lifestyle, patient goals would influence the choice between the established THP regimen and the more effective or potentially more toxic T-DXd regimen?
Yeah. So I think when we have approval of DESTINY-Breast09, which is forthcoming, this is going to be something that we are talking about constantly in the clinic. THP can still be an option, even if T-DXd and pertuzumab is approved, because T-DXd is approved in the second line. And so for which patients should we give T-DXd up front, which has more side effects than THP and then HP maintenance, or should we wait until the second line? So there's going to be a lot of considerations. We know from analyses of the Cleopatra trial populations and real world data that patients that do extremely well on THP are de novo patients, patients with HER2 IHC 3+, patients without brain metastases, patients without PIK3CA mutations. Now we're going to talk about this in the next case, but we also have a clinical trial called the PATINA clinical trial in estrogen receptor positive, HER2 positive patients that had a very long PFS with HP maintenance, endocrine therapy, and palbociclib. And so my ER positive patients, I am still planning on treating most of them with THP followed by this palbociclib, aromatase endocrine therapy, and HP maintenance. So people who I think we're going to think about TDXD with or without pertuzumab in the first line are certainly patients that relapse within 12 months of their adjuvant therapy. So that is already standard. Patients with, appreciable brain metastases, because TDXD does have very good intracranial penetration. Patients, potentially that, you're really worried about symptomatic visceral involvement, and you really need a quick response. Or potentially, we can even get as granular to think about patients with PIK3CA mutations because we know that they don't do as well with THP. And so there's actually going to be more of a tailored medicine approach as time goes on, and there's not going to be a one shoe fits all approach, which I think is the way the field has hoped to move anyway.
Great, thank you so much.
So case 2, I just gave a little bit of a preface for it, but we are going to talk about multi-drug maintenance strategies, including CDK4/6 inhibitors, because we recently also in the last year had the results of the PATINA clinical trial, which have been practice changing as well. So we're going to evaluate the latest evidence for adding CDK4/6 inhibitors in HER2 positive metastatic breast cancer. Also think about efficacy endpoints and toxicity profiles. So for case 2, we will go over a 63-year-old female with de novo metastatic ER positive HER2 3+ breast cancer. She undergoes induction with a taxane and trastuzumab and pertuzumab for 6 cycles with a partial response. She discontinues the taxane and proceeds to trastuzumab and pertuzumab maintenance. Now, she is also estrogen receptor positive, and so we want to add an endocrine therapy to her regimen. What is the optimal endocrine therapy strategy for this patient to add to her trastuzumab and pertuzumab? Is it tamoxifen? Is it an aromatase inhibitor? Is it an aromatase inhibitor plus palbociclib? Is it tamoxifen plus abemaciclib? Or is it fulvestrant? Remember, she is a de novo patient with no prior history of endocrine therapy. Okay, good answers. Now let's talk about the data.
So Dr. Sammons, can you tell us about the PATINA clinical trial for patients with ER positive, HER2 positive breast cancer, and how's this changed clinical practice?
Absolutely. So the PATINA clinical trial was presented at San Antonio Breast Cancer Symposium in December of 2024 and is actually the longest progression-free survival that I have ever seen with a single regimen in metastatic breast cancer, in all metastatic breast cancer. So it was a very, very exciting clinical trial. And essentially what this trial looked at was patients with estrogen receptor positive and HER2 positive metastatic breast cancer who had already received THP induction with the Cleopatra regimen. Patients had to have already completed THP induction, and they could not have had progression during the THP induction, and they were going on to maintenance. And they were either randomized to endocrine therapy added to their trastuzumab, pertuzumab, aromatase inhibitor or fulvestrant was allowed, but for most patients, it was aromatase inhibitor. The experimental arm was endocrine therapy plus CDK4/6 inhibitor palbociclib added to their trastuzumab and pertuzumab. The median progression-free survival with the addition of palbociclib was 44 months. And remember, this is after a 6-month induction already, versus 29 months in the control arm with just endocrine therapy and trastuzumab, pertuzumab. And so this was a very, very exciting trial to see. We've already been using palbociclib in metastatic estrogen-positive, HER2-negative breast cancer for almost a decade now. And so we're very familiar with the side effect profile of palbociclib. And this is really the first, clinical trial that has really shown us that we might need to think differently about how we're treating estrogen positive versus estrogen negative HER2 positive disease. And I think we will start to see the treatment algorithms of these two populations be differentiated, at least in the first line now. So I do think these were extremely compelling results. I have adopted this already into my practice. I know that they are going for regulatory approval, but I have adopted it into my practice already and, have received approval. So for patients that have ER positive, HER2 positive disease who are finished their induction and are going on to maintenance, trastuzumab, pertuzumab with an aromatase inhibitor, I am generally adding palbociclib at this point. Case 3, apply patient-centered and quality of life focused decision-making to personalize regimens in patients with brain metastases. Match the regimen with the intensity of tumor biology, disease tempo, and CNS risk. Adjust doses, schedules, or accommodations to mitigate toxicity and align with patient goals. So case 3 is a 49-year-old female. She has de novo estrogen receptor negative, HER2 positive metastatic breast cancer, and she received first-line THP. She was on HP maintenance for 36 months, and she had stable extracranial disease, but at the time, she developed brain metastasis 3 months ago and was treated with SRS. We're now doing another brain MRI, which shows 2 new sub-centimeter lesions. Her extracranial disease is still stable, and she has radiation to 2 new brain lesions. So in the last essentially 4 months, she has had 5 new brain metastases and stable extracranial disease. At this point, we do want to change her systemic therapy to a brain penetrant regimen because she has had recurrent CNS progressions. And she prefers a regimen without hair loss due to her career. She happens to be on television a lot, and she does not want to lose her hair or have hair thinning. And she has young children, and she feels like hair loss might be emotionally challenging for them. So applying this patient-centered, quality of life focused decision-making, what regimen do you consider or offer for this patient? Trastuzumab deruxtecan, TDM1, tucatinib, trastuzumab, capecitabine, carboplatin, trastuzumab, or neratinib, capecitabine. Okay, nice answers. Now let's talk about it.
So, Dr. Sammons, what are our 2 primary systemic options for this patient? And what are the pivotal trials that support their use in CNS disease?
Absolutely. So we have two regimens in metastatic HER2 positive breast cancer that are very, very active in our brain metastasis patients. The first is tucatinib, which is a highly brain penetrant HER2 tyrosine kinase inhibitor. Tucatinib is added to trastuzumab and capecitabine, which is a brain penetrant oral chemotherapy. So it's a 3-drug regimen: tucatinib, capecitabine, and trastuzumab. The clinical trial that evaluated that was called the HER2 Climb clinical trial. And in the brain metastasis patients, which was 50% of the population, including active and stable brain mets patients, there was an improvement in progression-free survival, intracranial progression-free survival, intracranial overall response rate, and overall survival in the brain metastasis population of this trial with the addition of tucatinib. And so that is a very nice regimen for patients. It does not have hair loss. That's not to say that it doesn't have toxicity, though. There is still certainly some diarrhea, some nausea. The pill burden is, not something to shy away from. There's a decent amount of pills that have to be taken. We have to monitor for liver function, but with the right tailored approach, patients can do pretty well on it. And so particularly for this patient who is just not ready for hair loss, that is something that I would certainly consider for her. The other regimen that is also highly intracranially active and would otherwise probably be standard is trastuzumab deruxtecan, which was approved based on the results of DESTINY-Breast03 in the second-line setting versus TDM1. We know from some small studies and more recently the DESTINY-Breast12 clinical trial that patients with stable or active brain metastasis do very, very well with trastuzumab deruxtecan. It has a CNS PFS around 12 months. It has an intracranial response rate around 70%. It has an overall PFS around 18 months. And so patients do really, really well with TDXD that have brain mets as well. But we could reserve TDXD for the next line for this patient. But I would probably for her just say, we can certainly try this now, and hopefully we'll get some time out of it. But I want you to start thinking about and preparing yourself mentally, for TDXD in the coming years.
Let's compare the intracranial efficacy data. How do the intracranial response rates, CNS PFS data from DESTINY-Breast12 and HER2 Climb stack up?
Yes. So, we're always told not to do cross-trial comparisons because, to be fair, the DESTINY-Breast12 and the HER2 Climb trial populations are very different. DESTINY-Breast12 is mostly a second-line population, whereas HER2 Climb is mostly a third-line population. So, it's not probably fair to completely compare them, but that's all we can do, right? The intracranial response rate of TDXD in the second line is probably around 70%. The intracranial response rate of the HER2 Climb regimen in the third line is around 48%. The CNS PFS of the HER2 Climb regimen in stable brain mets is a little bit over 12 months, actually. And the CNS PFS of DESTINY-Breast12 is around 12 months too. And so, I think they're both very active. I think in terms of intracranial response, the TDXD trials were a little less pretreated, but the response of TDXD is a little bit higher. And so if I have an active CNS patient who's trying to avoid whole brain or doesn't have any radiation options, I will lean towards TDXD first.
Beyond efficacy, the toxicity profiles are very different. Can you contrast the risk and management of TDXD-induced interstitial lung disease with tucatinib-associated diarrhea and hepatotoxicity?
Yeah, sure. So, with TDXD, I tell my patients that there's about a 50% chance of alopecia, 30 to 50%. And the main things that are going to bother them are actually fatigue and nausea. And so we have to be really aggressive about their anti-nausea medications. 3-drug regimen, have antiemetics at home. I do give them steroids 2 days after, just Dex, 4 milligrams BID. And then if it's refractory, I'll even try low-dose olanzapine for a few days after. So those are really the main things that patients are going to, experience. There can be a little bit of diarrhea or even constipation because of all the antiemetics. And then we also counsel them on the interstitial lung disease risk, which is between 10 and 15%. And so must call in if you have cough, shortness of breath, anything like that. With tucatinib, it's more, there's certainly some mild diarrhea, better than the previous HER2 TKIs that we used to use, neratinib. But we send them home with an Imodium script. It's important for everybody to stay hydrated. There can certainly be some nausea and some fatigue with the tucatinib-based regimen. And then we have to, of course, monitor their liver enzymes for hepatotoxicity.
So for this patient, how would you personalize the choice? What patient factors, such as underlying lung disease, liver function, or tolerance for oral versus intravenous therapy, would steer you toward one regimen over the other?
Yeah, so for this patient in general, patients will often tell you up front what toxicities they are most scared of. This patient just said, I'm not ready for hair loss. It's a minority of patients that, with metastatic disease that say that, but there are certainly patients out there that are just not ready. And if you have a reasonable choice, which I certainly think the HER2 Climb regimen is a reasonable choice for her, then, we certainly need to respect that. In terms of oral versus IV, some patients have preferences on that too, but it's not as relevant here because all of these patients with HER2 positive metastatic breast cancer are going to have to come in every 3 weeks for their, trastuzumab or their ADC anyway. Until we have programs that can treat patients in their home, they're going to have to be coming in for that. So in the tucatinib regimen, yes, most of it's oral and there are a lot of pills, but patients still have to come in for trastuzumab. So I don't think that would, impact her so much. Certainly if patients have if they have a history of interstitial lung disease or certainly ongoing interstitial lung disease, then I would not treat them with T-DXd. I mean, that's on the more rare end. We certainly can treat patients who have lung metastasis or lymphangitic carcinomatosis with T-DXd. So, we still have to be doctors. We have to understand patient preferences, patient comorbidities. Certainly on any HER2 targeted therapy, we need to be thinking about their heart history. Patients with HER2 positive MBC should be getting regular echocardiograms anyway to monitor their ejection fraction on HER2 targeted therapies. But for this patient, in this case, she really didn't want hair loss. And it's, tucatinib, the HER2 Climb regimen doesn't have much hair loss, whereas T-DXd certainly can.
Great. Dr. Sammons, thank you so much for telling us through a really impressive 3 cases and answering so many questions as we go. Thank you so much.
Yeah, thanks for having me. Shifting landscape, lots changing. Happy to be here.
What a really great session. And now we've got some time for questions from our audience, and we've got some time live with Dr. Sammons to let her tackle some of those. So Dr. Sammons, thank you so much for joining us and for having such a great session talking through some really interesting cases and some of the latest data.
Sure, happy to be here.
We've got a really great question from Jem in our audience, and it's this: do we know how long we should actually continue HER2 targeted maintenance, or is there an optimal duration before thinking of de-escalation?
So, in the metastatic setting, currently the treatment paradigm is you treat patients, at least for Cleopatra, you treat patients with induction, a minimum of 6 cycles of taxane-based chemotherapy, and then you put them on maintenance. There is, at this time, we continue maintenance until time of progression, which will happen for most patients. Now, about 15 to 20% of patients treated with first-line maintenance, trastuzumab and pertuzumab, have these really, really long progression-free survivals. They have not progressed at 7 or 8 years. And I think what this person might be asking is, what Jim might be asking is, can we take these patients off therapy? Because that's a question that we've been asking ourselves, at least here at my institution. We have a phase 2 trial that has taken patients that have essentially been NED after at least 3 years of maintenance HP, and it's looked at stopping it and how many of those patients, at 24 months might be, haven't relapsed, might actually be cured. That trial is fully enrolled and will present this year. But at this time, until we see that data, maintenance is generally continued until time of progression, intolerable toxicity, or intolerable toxicity. So progression or intolerable toxicity. Does that answer the question?
Yeah, I think it does. The next question we've got from Alex is this. He says, "Thank you so much. If a patient is on the Cleopatra regimen and has oligoprogression, would you add CDK4/6 or switch to Destiny Breast09?"
Ooh, good question. Do you want the textbook answer or the Sarah Sammons answer?
Can we have both?
All right, I'll give you both. I'll start with the textbook answer, which, there's really no nuances in how we treat oligometastatic progression, or that you can radiate. And so the textbook answer would be move on to TDXD. But as someone who treats these patients in the clinic, if I have a patient who's been on HP with an amazing quality of life, because these patients in general have an excellent quality of life. Let's say they've been on a couple of years and they have some mild progression in the lymph node, or, a very small lung nodule or something else, and they're ER positive, to this person's point. I might actually, transition, if they're on an AI, I might transition them to fulvestrant and a CDK4/6 and see if I can get some more time out of that. Certainly that's outside of guidelines, that's outside of what has been studied, but I would probably give it a shot.
I've got a question here from across one of our channels, which is around the design of the PATINA trial. And the question is this: for a patient who has only stable disease or a very minimal response after 6 cycles of THP induction, would you still feel confident adding palbociclib based on the PATINA data, or would this scenario suggest a more aggressive biology for which maintenance strategy is less effective?
That's a really great question. PATINA is going to be published very soon, so then everybody will be able to sort of, if they don't have the presentation slides, they'll be able to look at the forest plots. But Dr. Metzger did look in the subgroup analyses at patients who had a PR or CR to their taxane-based induction versus stable disease. And patients seem to benefit from the PATINA regimen regardless. And I think that is because, you're taking them off chemotherapy, but you're actually switching them still to a highly effective strategy. Think about it. These people are still estrogen receptor positive, and there's crosstalk between estrogen receptor positivity and HER2 positivity.
and then you're putting them on an endocrine therapy and a CDK4/6 inhibitor, and continuing their trastuzumab and pertuzumab. So you're giving them an entirely different effective modality. And so for patients with stable disease, I would still consider it. And in the PATINA trial, they still drive benefit.
I think we've got time for one last question because we've had such a great session, but I'll choose this one. Following the impressive PATINA data for endocrine receptor positive, HER2 positive patients, how do you reconcile this with the first-line data from DESTINY-Breast09 for a high-risk endocrine receptor positive, HER2 positive patient, such as the one with the early relapse and symptomatic visceral disease? Would you favor the rapid deep response of T-DXd plus pertuzumab, or would the PATINA style approach with THP induction followed by quadruplet maintenance be your preferred strategy?
It's a brilliant question. And it's a question that we're all asking ourselves in the community, because we really like the PATINA data. We really like the idea of optimizing endocrine therapy and getting 44 months for our patients with ER positive, HER2 positive breast cancer. But there's also no question that T-DXd is a very effective regimen and was superior to taxane HP in the first line. So we're in a data-free zone with the question of, can you do a T-DXd induction and then move on to a PATINA-like maintenance? I will say there are trials being designed that will look at that question because it's what everybody's asking. If I had a patient who I really felt like I needed to give T-DXd plus pertuzumab induction to, very heavily symptomatic, maybe CNS disease, and I gave them induction, and they had a beautiful response, I would be tempted at a certain point to take them off and put them on maintenance. The question is, we don't know the optimal period of induction. We don't know if we should induce people for 6 months, 12 months. Maybe we'll see that data at some point, but I think if you're going to induce someone with T-DXd, we're kind of flying blind. Certainly can take them off, and we have great options once they develop toxicity. I do think it's reasonable, if a patient's in a PR or certainly a CR after a certain period of time, to give them a shot at a maintenance strategy. But it's tricky because we're in a data-free zone.
Dr. Sammons, that's us at time. We don't have time for any more questions, but we are so grateful for you tackling so many with us today, and for sharing some of the latest data with us in case-based environment. So we really appreciate such a great presentation. Thank you.
Thank you. It was fun.
I'm just going to bring up on the screen a QR code, which if you would like to claim a CME certificate for today, you just need to scan that QR code. We're also going to pop the link to that certificate form in the chat on Medall, and you'll be able to click that link and claim your certificate. Please give us some feedback. Tell us your thoughts. We love putting these sessions on. We hope they're really useful for you. If there's anything that we can do to make them better, please let us know. I hope you find it really useful. And guess what? We're going to be testing a little bit about what you've learned during this session in that forum as well. So I hope you find it really useful. Claiming a certificate is completely free. We don't charge for any of our education, and it's a really big part of our philosophy. A couple of people were asking how they can watch the first webinar. It's available on demand at medailleducation.com, and that was with Professor Rupert Barch, who's giving us an overview of some of the evolution of thinking in this space, and it's really worth watching that webinar as well. You'll be able to claim a certificate for watching it on demand. Before we finish today, I've got a really important message for you, and that is from a patient. And we like to focus our education all around patients. So you'll have seen case-based education in today's session, and I had the really great honor of talking to Jenny Burkholder, who is a patient who's experienced metastatic breast cancer, and we really want to thank her for spending some time with us. And she's working in advocacy and collaboration with Living Beyond Breast Cancer, And whilst you're filling in that evaluation, I'd really love if you can spend a little bit of time listening to Jenny's story, because it reminds us what this is all about. I'm going to hand over to the interview with Jenny Burkholder. I am really honored to be joined by Jenny Burkholder. And Jenny is a patient who has experienced HER2 positive metastatic breast cancer, and she's going to join us and share a little of her story. Thank you so much for joining us, Jenny.
Thanks, Phil.
To begin, I wanted to ask if you could share a little about your life at the time you were diagnosed with HER2 positive metastatic breast cancer. What was the initial treatment experience like for you, both physically and emotionally?
I was initially diagnosed with early stage breast cancer in 2012, and it was ER/PR positive and HER2 negative. And then I went through the whole course of treatment. And then in October of 2019, I was experiencing pain in my lower back and my sternum. And for a long time, I thought I had a yoga injury, because I had been in a yoga class and I had lowered into chaturanga, into low plank, and I felt this like ripping, burning sensation across my sternum. And I was like, uh-oh, I think I've overdone it, which of course led me to like pop into handstand. So I spent from October of 2019 until December of 2019, moving from physical therapist to doctor to, general practitioner. I had a X-ray of my skeleton and lungs, and everybody was saying to me, "Oh, this is just a yoga injury." And finally, I went to a physiatrist who was the doctor to my physical therapist, and he said, "I suggest you go to your oncologist." And I thought, my oncologist? Why would I need to go to my oncologist for a yoga injury? And my oncologist, even at the time, said, "I think you have, probably maybe a muscle injury or something that's going to take a long time to heal. But because I'm in the business of cancer, let's give you a CT and PET scan." And what we come to find out is that I have metastatic breast cancer that is not only in my sternum, it's in my L4, it's in my L5, it's in my L1, L3, my T4, it's in my hips, so it's everywhere. And after an initial biopsy, we found out that it was no longer ER/PR positive, HER2 negative, but I was, as they say, wildly HER2 positive. And that would account for its sort of spread through the different bone areas. That was actually, I got the phone call on December 31st of 2019. So it was New Year's Eve. And it was a strange, the whole thing was a strange sort of revelation. I guess for me, I never thought about the fact that I might have metastatic breast cancer. It never crossed my mind. And I think at that point, if I look back, because I had had a chest x-ray by my general practitioner, it was almost like a red herring. Like because they didn't see anything on that x-ray, little did I know that that actually wasn't looking into the bones. I just thought I had a yoga injury. So it was shocking. It was shocking. But what happened was, because I was so wildly HER2 positive, which I thought at that point was actually sort of going to be my end. It turned out that because I was so wildly HER2 positive, and I had not been HER2 positive to begin with, I had never received any of the treatments specifically for HER2 positive breast cancer. So my first line of treatment was to use one of the drugs that had been used for decades to treat HER2 positive HER2 positive breast cancer. And that worked immediately. It worked immediately. So I felt like the pain was gone. My oncologist, I was getting scanned every 3 months, and immediately that was my biggest deal, was that the pain was eliminated. And so from there, because I had been through breast cancer treatment before, I was very much like, okay, here's what we do. I'm fairly practical in that regard. And so I knew, because it was contained to my bones, and because the treatment was working, I felt that glimmer of hope. That was 2019, and now it's 2025.
That was 2019. It's now 2025. As treatments evolve, there are often discussions about adjusting the intensity, sometimes adding drugs, sometimes reducing them. Can you tell us a little bit about how you and your care team have balanced the goal of controlling the cancer with the goal of preserving your quality of life? And was there ever a point where you discussed changing a dose or a drug to manage side effects?
That's a great question, especially in the metastatic community at this point. I was initially on a treatment plan that included not only targeting the HER2 breast cancer, but also targeting the ER/PR positive. And then about 2.5 years into my treatment, I had a progression in my L1, and then I had a progression in my L3, in my lumbar vertebra. So at that point, the discussion was about, what do we do now? You know, something at this point is not working. I was given a biomarker test which also showed that I had a treatment induced mutation. So this becomes a major pivotal point about what to do next. And that was in 2022. So I was, at that point, my oncologist was no longer comfortable with the treatment plan that I had been on. So I received some targeted therapy, some targeted radiation therapy for the L1 and L3 and any spots that were in my pelvis and such. And then I was changed to a new drug that was targeting not only the HER2, but also had a low dose chemotherapy component to it. It's a drug conjugate. And the first couple doses of that, I was so sick. I had extreme nausea, nausea and vomiting, extreme fatigue, no quality of life. I was out for a week, and that just wasn't doable. So that was probably around the fall of 2022. By the winter of 2023, I advocated with my care team for a dose reduction. So the first thing I advocated for was a dose reduction, and my oncologist was on board. This was a newer drug. There was many conversations in many spaces about reducing the dose. His primary concern at that point was my quality of life, and when I was detailing my symptoms, he agreed that that was not acceptable. So that was my first conversation with him about the dose reduction. As we came, that was, like I said, fall of 2023. As we continued on this same medication for a couple of years, I've been on it now for a couple of years. My next conversation with him was about frequency of treatment. So the initial treatment was a dose reduction every 3 weeks. And then we started to see, because I'm scanned every 3 months, we started to see that there was no evidence in the CT scans of active cancer, that we weren't seeing, we were seeing healing where I had received the stereotactic radiation, and we weren't seeing any new spots. We weren't seeing any spots in the liver. We weren't seeing any spots in the lungs. So then I advocated for not only a dose reduction, but a time between doses. And so I went from the highest dose every 3 weeks to a lower dose, and then I had another dose reduction that I now receive every 5 weeks. So those were important conversations for me to have with my oncologist, because that has increased and greatly helped my quality of life.
Sure. You've mentioned a couple of times your care team and conversations. What does truly effective communication look like from your side of the examination table? Could you share an example, perhaps, of a conversation that made you feel empowered, heard, like a true partner in your care?
Yes, I I perhaps had a bit of an advantage since I've been with this care team since 2012. So, by the time I was re-diagnosed in 2019, we had a long history. And that not only includes my oncologist, but it also includes my oncologist nurse practitioner, whom I had developed a very close relationship with. So those conversations were, I think the most empowered I felt was when I had progression in 2022 and we were talking about the next course of action. And as a person, my role, or what I feel helps me the best, is I did a lot of research. I also got a second opinion. And sometimes I actually got 3 opinions. So even though I very much trusted my oncologist, I know that I live in a city that has some access to healthcare and oncologists. So I was very lucky to have the opportunity to get probably 3 opinions. So I was able to amass my knowledge about what the next treatment plans were. And so I was able to have that conversation with him, and we went back and forth. And he would suggest certain things to me, and he would give me the sort of side effects. For example, like I said, I had a treatment-resistant mutation. So were we going to treat that? Were we going to treat the HER2? How were we going to continue to treat the ER-PR piece of it? So I think that was the most empowered I felt, was when, I was given a couple months to actually sort of like learn what the next treatment was. And he was always willing to engage all of my questions. And my nurse practitioner was willing to engage all of my questions. And there were many of them. So that was a pivotal moment. Since then, I am now in a situation where it seems as if I have no evidence of active disease on the treatment that I'm on. So I'm back in conversation with my oncologist about next steps, and we'll see. At this point, I'm on the treatment plan that I am on. And so, we're at another pivotal point, but it's a different pivotal point. So I'm happy to be here.
Healthcare professionals often talk about quality of life as an endpoint. For you personally, what does a good quality of life mean when living with this diagnosis? What are the practical daily things that matter most to you, that you want your clinical team to understand and protect?
Any oncologist needs to be talking with their patients about quality of life. And it means different things to different people. And I appreciate you asking about my definition of it. And for me, I have 2 teenagers. I have one of whom has graduated high school, and the other one is now a junior in high school. So my most important quality of life is making sure that I am able to be present for them. And on top of that, quality of life means to me being physically active. That also includes, a lot of yoga and meditation, being physically able to walk, and I love to dance. So all of those important ways that I can exercise my body are important. I think one of the hardest parts about the 3 months before I was diagnosed with metastatic breast cancer, that was actually, I think, harder than actually getting diagnosed with metastatic breast cancer, was I was in so much pain. I couldn't practice yoga. I couldn't even get my shirt off, so the quality of life also means to me not being in pain. So that takes a lot of effort. I'm not only, I not only see a oncologist and my nurse practitioner, I also have a lymphatic massage therapist. I also do acupuncture, and I also have, a daily yoga and meditation practice. So those are the parts of quality of life, is that, making sure all of those parts are working together so I can be present for my kids and for my husband and for my family. Yep.
Your treatment has likely involved managing different types of therapies, from infusions to oral pills like endocrine therapy or CDK4/6 inhibitors. How important was it to have support not just from your oncologist, but nurses, pharmacists, support organizations in managing your treatment schedule and any side effects?
So important, so important. You know, I think of it as a team, and I have my team is my care team, my cancer care team. My team is, Living Beyond Breast Cancer, an organization I've been part of for many, many years, and their access to information and community. My teams are my friends and family. My teams I've got many teams, my spiritual community, all of the ways. So I often relied and depended not only on, trusted information and access to resources, but like I said, also access to second and third opinions. And another important part for me has also been access to other women who have been on the treatment plan before me and have experienced the treatment that I'm on and have their own stories. So I often spoke with women who are on the same medicine that I'm on, or treatment plan or whatever, or have the same oncologist that I do, so we can share our stories. So that's also been very, very important. And I also think that contributes to my quality of life. Absolutely, is having those resources.
And finally, Jenny, if you could leave our audience today of dedicated clinicians with one key message, one piece of advice that you believe would make the biggest difference in the journey of a patient with HER2 positive metastatic breast cancer, what would that be?
This is such a great question. There's so many things I'd like to say, but I think one of the important things is that this is a human business. This is human to human. When we talk about cancer care, it's important to recognize that the patient sitting across from you is human. I mean, I know that seems really obvious, but it's sometimes neglected. We are not numbers, we are not statistics, though in cancer care we are also that, but we are also humans living in human bodies. So, and that's important to recognize, because side effects have different effects on women's, and bodies. And, just because it's a side effect for one person doesn't necessarily mean it's going to be a side effect for another person. And quality of life is different for each of us. And so having that conversation with your patients about what quality of life looks like for them and how the treatment plan is affecting or helping that is so important.
Jenny, thank you so much for joining us today. We are so grateful for your time, and we do this because we want to hear about the human story. So you've brought that to a close in a really wonderful way. So thank you so much for sharing with us and bringing a really important perspective to our education.
Thank you, Phil. This has been a treat, and I hope it's informative and insightful.
Thank you. What a really powerful message, and exactly why we do this education. I hope you found that really interesting and impactful, and I hope that it brought everything together for you, which is what this is all about at the end of the day, which is a patient. I'm going to bring up on screen the QR code again, just in case you missed it earlier. If you would like to claim a CME certificate, you just need to scan that QR code, complete a very short evaluation, and you'll be able to claim a free CME certificate for this session. If it's your first time having joined us today, it's been an absolute pleasure to host you. I hope you find it really helpful and that you'll be able to implement some of what we've learned today into your practice either now or at some point in the future. And you'll be very welcome at any of our upcoming events. You can find them all listed at medaleducation.com. And they're always free, always open access. You'll be very welcome at any of them. That just leaves me to say thank you to you. Thank you for joining us today. Thank you for participating so actively in this session. And we hope to see you at one of our events sometime soon.